Everybody, welcome back to another Monday live stream. This is Kathy Randall from Synapse Care Solutions, and I am excited to be kicking off this month's very special live stream series with Code Lavender. So I hope that you'll enjoy this replay where Dr. Lochner shares with us the foundations of what a Code Lavender program is, how she got it started, the impact it's had, and some amazing results. This was a presentation from December 2020, so it's been quite a while, and you can all remember what life was like back then. I hope you'll be inspired with everything she's done and think of ways that you can support your staff using something like this. So I hope you'll enjoy this, and I'll see you at the end. Dr. Megan Lochner is a practicing OB in Long Island, New York, and so you can imagine the things that she's gone through as we've all watched New York over the last year, but also just focusing on staff wellness. And this was not something that started during COVID. This is something she's had a passion for years. And we're just really grateful for your time and your expertise and your passion. And we cannot wait to learn from you today.
Oh, that was a lovely introduction. Thank you. I'm going to go right ahead. And can you guys see that? To introduce myself, as you said, I'm a general OBGYN. I have always lived in New York for my training. I went to Stonybrook University Medical School. I did my residency here, and I've been an attending physician here for 12 years. I do general obstetrics and gynecology, and I wanted to just show this photograph to introduce you to me because this kind of shows who I am. That's me on the left, and that is my business partner, a fellow obstetrician. And I had the joy of delivering her baby, so it's baby Rosie. But I love this photo because it was taken by a nurse, and it was a candid photo. And she really captured who we are as obstetricians. And I hope to always present myself looking that happy and loving my job to our nurses, because we also have to support one another and be positive for one another. So that is how I like to introduce myself. When I started my practice 12 years ago, the senior obstetrician said this to me on my first day. He said, Megan, your job is to make sure every patient feels like they were the most important patient you saw that day. And I think as nurses and as doctors, this is really important to remind ourselves, because we play such an intimate and important job in such a special part of their lives. But it's really hard to always put your best foot forward, because we all have our own baggage that we bring to work. And sometimes some of that baggage comes from work. And so that's where I come from. So how can we, as providers, as nurses, as doctors, provide the best care for our patients? How can we really be compassionate providers when we're suffering inside? We've all heard of the second victim. This is no news. Dr. Wu first mentioned it back in 2000. Patients are the first and most obvious victims, but the doctors and nurses also are wounded by medical errors, and we're the second victims. Further defined in 2009 by Scott. And I think this is really interesting, this definition, especially where it says that we feel personally responsible for bad outcomes of our patients. And we feel we failed them, and we come to second guess our own skills and our knowledge when these things happen. Code Lavender is a code. It's a code like any other code. It's like a code blue, a code pink. It's an emergency code for a mental health emergency. And it's a mechanism to initiate a rapid response to the emotional needs of staff when there's an adverse event. We provide psychological, emotional, and spiritual support for the staff, depending on what they need. People ask me all the time, does this constitute a Code Lavender? I get text messages, this happened, can we have a Code Lavender? Any event that causes grief, distress, sadness, vulnerability, or self-doubt can be a Code Lavender. It's not just about a bad patient event. It could also be group distress. It could be a high acuity unit. It can be the death of a colleague or the sickness of a colleague. Anything that creates distress can be a Code Lavender. Code Lavender began at the Cleveland Clinic with a group of nurses. They demonstrated the need for peer support for the providers. And their culture at that location was very focused on the spiritual support. So they had a lot of holistic Reiki, massage therapy, and spiritual support. Johns Hopkins had their own program called RISE, and that stands for Resilience in Stressful Events. And that stemmed from the story of Josie King, who was a little girl who immersed herself in a scalding bath and had burns throughout most of her body. She went to Johns Hopkins and received excellent care and was pretty much on her road to discharge when unexpectedly Josie died. And it was determined that it was from unrecognized dehydration and the misuse of narcotics. So this deeply affected the staff and triggered them to create this program. Their program is very peer focused. It's a 30-minute response, and there is a chaplain and a nurse manager, but it's very much peer based, where it's just fellow nurses, fellow doctors responding. And we'll get into that a little bit when I talk about our Code Lavender. So the story of how our Code Lavender began is my story, actually. In November of 2017, I had a catastrophic obstetrical hemorrhage. As you all know, hemorrhage is nothing new in obstetrics. We deal with it all the time, and we're trained to deal with it. But this was a different type of hemorrhage. I was sitting in a conference. I had no clinical responsibilities, and my partner texted me, could I assist on a twin cesarean section? Sure, no problem. I showed up, never met the patient before, introduced myself. We had a great delivery. Two beautiful little girls. We were laughing. Everybody in the room was happy. We were taking pictures. And then the patient was bleeding and she had atony. We did what we do to treat atony. And unfortunately, I made the decision we had to do a hysterectomy. And the patient was actually really okay with it. She said, I have my two beautiful babies, do whatever you have to do. We did the hysterectomy in probably 10 or 15 minutes. The case went great. We finished, closed her up. She got 2 units of blood and she went to the recovery room. And then I went to my office hours and I was to be on call that night at 11 p.m. I got to my office and I left my phone on my desk and I saw a few patients and the nurses ran in. They said, Dr. Lochner, your phone's blowing up on your desk with text messages. I said, okay. So I look and it was my partner. And basically she just texted me, the patient's crashing. And I picked up my keys and I went to the hospital. I didn't think twice. And the whole way there, I was thinking, how could she be crashing? What happened? She wasn't bleeding. It was a straightforward case. She can't be bleeding. It must be a pulmonary embolism. Maybe it's an amniotic fluid embolism. And I'm going through the whole list of things in my head. And then I got there and I looked at her and I was like, we got to take her to the OR. And at that point, her pulse was about 180. Her blood pressure was undetectable. She was obtunded. The anesthesiologists were trying to get an A-line in her. And we opened her up and just liters of blood came over the sides of the bed. And I thought to myself, she's going to die. And I called a code Noel, which at our institution is an obstetrical hemorrhage code. And nobody came to help me. And I looked around the room and I realized, this is it. I'm it. I'm the most senior person here. Nobody's coming to help me. And this lady's going to die. And I reached inside and I found the vessel that was bleeding somehow and I clamped it. And I just remember looking at the anesthesiologist and I said, I stopped the bleeding. I stopped the bleeding. And she looked back over at me and I realized it's too late. And it wasn't too late. She lived miraculously. She got, I don't remember, 20 something units of blood and then blood products. And she was intubated and went to the ICU. And I had to go talk to her family. And they'd never met me before. They didn't know who I was. And they just kept asking, what happened? I thought the hysterectomy was supposed to save her life. What happened? Why did she bleed? What went wrong? And I tried to explain to them what could have happened. And those words in my head were, I failed her. I failed the patient. I took her uterus from her and she still may die. And at that moment, I didn't think that I was really equipped to do what I was doing. that maybe I need to do something else. But in the moment, I had to still take care of the patient. It wasn't over. She wasn't out of the woods. So I went to Starbucks and I was just numb. And I remember I got a text from a nurse from our NICU. And she really wasn't even a friend. She just was somebody who had my phone number. And she said, "I'm sorry you're having a bad day at the office. You're an amazing doctor." And that was what I needed to hear at that moment. I just needed somebody to tell me that I could do this and that I didn't fail my patient. And so I started to cry and I left Starbucks and I went to my car because that's where we all go to cry, the bathroom, the car. And I went to my car and I just cried. And I called my best friend and I said, "I can't do this anymore. I can't." And my anesthesia friend who had come into the OR to help, he called me and he said, "Where are you?" I said, "I'm in my car." And he said, "I need to take you away from the hospital. Let's go get something to eat." And I said, "No, I can't leave the ICU. I have to go back in. She's not out of the woods." And he said, "No, you need to step away." So he took me to Chili's and we talked and I cried. And then when that moment was over, it was time for my call to start. It was 11 o'clock at night. And so I went back and I sat with the patient all night, but it was a busy night. I had a fetal demise come in full term. I had to deliver a dead baby. Lucena wouldn't come. She hemorrhaged. I had other deliveries that night as well, and I never went to sleep. And then at 7 o'clock, I had to go do a deep dive about my case. And I walked in the room, and I remember there wasn't even a place for me to sit. I was leaning on a table on the side, and I looked around, and none of those people were there. They don't even know what happened. And they were all there to criticize my case and tell me what I did wrong. And that's why I felt like they were blaming me. And they all had gone home to their families and had dinner and gone to bed. And I was still here. I never went to sleep. And nobody asked me if I was okay. Not one person asked me if I was okay. And that was the moment when I said, I will not let this happen to anyone else ever again, because none of us deserve to ever feel that way. So I went to my resident mentor group and I told them very honestly. I cried in front of my residents and I told them, "What do we do? What do I do? How do I come back to work tomorrow?" And we decided that we were going to be positive and we were going to make a survey and send it out to our department to try to figure out what we can do to help people in these bad situations. So we distributed a survey. It was predominantly about debriefing after bad incidents, which I know most of you do. You all get together afterwards when things have settled down and talk about what did we do well, what could we have done better, were there systems errors in place. And so we had 127 responders from maternity and half were nurses. And 85% had been involved or witnessed a bad patient outcome. Of those people, 80% did not feel that we had a current system in place to help providers deal with this. 80%. And 44% had experienced insomnia, sadness, feelings of fear for less than 2 weeks, and 20% almost for more than 2 weeks after that event. In the fall of the same year, one of my colleagues had a patient die on the operating table during a routine hysterectomy. She bled to death. She had an unrecognized cancer. And our department was devastated. The surgeon was devastated. The residents were beyond devastated. The nurses were devastated. And I knew we had to do something. So I rented out a wine bar and I invited every person involved, every nurse, every scrub nurse, circulating nurse, the PACU nurse, the pre-op nurse, all the physicians involved, the anesthesiologist. And we just got together and we just were with one another. It wasn't a psychology session. We didn't give therapy. We just were together and supported one another. And I love this photo because this was my first Code Lavender. And the two gentlemen in the blue shirts in the middle are the anesthesiologist, his first week out of fellowship, and the gynecologist, the surgeon. And you can just feel the support and the love around them to say, look, we're here for you. And so that's how it started. So I'm not going to go through the details of how to start something like this with your organization, because every organization has a completely different hierarchy, so to speak. But what I learned really quickly is that it's really easy to step on people's toes and that everybody wants credit for everything. Having said that, I basically started with our CMO and our CNO and just went from place to place and tried to figure out who would support me. I found a group of people in maternity and actually mostly NICU who gravitated towards the idea of Team Lavender. And we just started meeting monthly and figuring out how we could put this all together to allow people to have access to a Code Lavender throughout the whole hospital whenever they needed one. We started off in maternity and NICU because we had to start small and then get bigger. And so we sent out a pre-Code Lavender survey to our NICU and our nurses. And the responses were similar to the debrief survey. 30% of those who responded had distress that lasted for over 2 weeks after a bad event. Not many of them had formal meetings with their colleagues for support. A lot of them discussed it informally with their colleagues. But 33% said that they would have benefited from counseling and didn't receive any. 6% considered a leave of absence, and 15% considered changing their position. When asked if they were aware of resources or support systems, 46% responded no. And only 25% said yes, and they actually knew how to access them. This was not acceptable. So we launched our pilot in 2019. We distributed information cards to the staff, just describing how you call a Code Lavender, which I'll briefly tell you, explaining why we were doing this and what the responses would be. Our mission statement was to increase awareness of the impact of adverse events on staff, the need for support, and also respite. If you remember my story, my friend forced me to leave the hospital. He said, you have to leave. You have to be removed from the situation. You have to get away. And that's really hard because our clinical responsibilities don't go away. And usually we're short-staffed. Probably everybody's short-staffed, right? So how do you find a way to get away? That's what a Code Lavender does. So we are just trying to create this culture of compassion amongst our staff. We also teach ways to cope, which I'll also show you briefly. In our hospital, you call the operator. You tell them you need a Code Lavender. It's not an overhead code, it's silent. A chaplain receives the page, calls you back, figures out what you need. And we ask, what do you need? Do you need to leave the unit? Do you need a chaplain? Do you need a psychologist? What do you need? And we work then to provide that. Phase one of the response is for an acute crisis. When somebody literally can't deal with what's happening, we will actually have a chaplain who will remove them from the situation. Our nurse managers are essential because they are usually the person who finds the backup, and they really have to be on board with the Code Lavender. We have a delayed response within 24 hours. We have group-led reflection. What's really important with this is figuring out a day and a time that everybody can be there, and sometimes we have to do it in phases. And then finally, for really bad situations, we have an emotional debrief about a week later, and we assess how everyone's doing, and do people actually need to be paired up with a therapist at this point? So we provide therapy. We have our employee assistance program director as part of our team. So she will get you whatever you need, whether it's time off, whatever it is. And then finally, our team debriefs once a month, and we go over our codes, we go over what went well. And the best part of that debrief is that we do our own stress reduction. So we do aromatherapy, we do deep breathing. And this is mandatory. To be part of Team Lavender and to be a peer supporter, you have to attend these meetings. These are just examples of some of our codes to date. We've had many more, but just to show you the broad spectrum, we've had staff members assaulted by patients. We've had them threatened their lives. Unfortunately, we just recently had the death of one of our colleagues who was murdered. We have had lots of terrible things. We had a 13-minute shoulder dystocia, which for anyone who's at the bedside for a shoulder dystocia, that should make you want to vomit. Baby turned out okay. So this is just to mention, this is not a psychological debrief that we're doing. We're not psychiatrists, we're not therapists, we're not trained to be therapists. We're just peer supporters. We're the person who makes you a cup of tea and sits and just listens and lets you cry and says, it's okay. It's okay that you feel this way. It's important when you want to implement something like this that you sell it, because like I said, not only are you stepping on toes, but people are going to want to take credit, and they're also going to want to take credit for something bigger, like employee engagement and the reduction of staff turnover and burnout, which during COVID, we all know is inevitable. We did put another survey out 8 months after we did our Code Lavender pilot, and what we showed was that we actually turned the numbers around completely. And now 80% of people were aware of resources, and over half of them knew how to access them, which was pretty awesome. We asked, do you feel that there has been improvement over the past year in the culture on your unit? And 34% said yes, definitely. 48% yes to some degree. And I'm really proud of those numbers because I've been at Stonybrook for 21 years, and I can tell you that the dynamic between maternity and NICU used to be hostile. It used to be accusatory. They put the vacuum on 1,500 times. No wonder why the baby has a cephalohematoma. And we'd be like, why are you documenting it? That's not what happened. And so there was a lot of blame between the units. It's gone. In the year that we've been doing this, we are on each other's sides. We back each other up. I can't tell you how many times that we have a bad delivery. The NICU team comes back over to check on the staff on labor and delivery. The labor and delivery team goes back to NICU to check on the staff taking care of the baby. And most of the codes, they're called by the other department. So NICU called the Code Lavender for L&D and vice versa. And it's like this amazing dynamic that's changed. And if you talk to our nurses, that's what you're going to hear, is how much we've improved the relationship and patient care. These are some of our responses after some rough nights. We did some ice cream socials and things. And then in March, this probably makes your stomach turn, makes mine turn. But then we had, as they say, COVID hit. The COVID, as they call it in New York. I don't know if they do that other places, but the COVID hit. In March, our disaster mental health team assembled. This is a mental health team that is formed for things like 9/11, when we had 9/11, for mass shootings, for huge car accidents, for these huge responses for staff support. They had no idea what they were going to do to help our staff get through a pandemic. And so they actually invited me, of all people, to come to their first meeting just to see what Code Lavender could bring to the table. And a subgroup formed. We just gravitated towards one another, and we have become the tightest group of people. There's about 7 of us, and we have done really amazing things for our staff. And so I just want to briefly show you some of the things that we did. First of all, our Code Lavender looks a lot different now. We're in a spaced out room. We're only allowed to have, I think, 10 people at this point in the room. We're 6 feet apart. We wear masks. We do not have food or beverages. We're not allowed to even have aromatherapy. However, we still have wonderful responses, and we also offer them on our Teams app, Microsoft Teams, which is really helpful. We created an employee respite room. We took a unit in our hospital. It was the ped psych unit, and it's got 10 or 12 beds, and we transformed it. We have music playing, we have aromatherapy, we have snacks, we have tea and coffee. It's quiet, it's safe. You can take a shower. You can take your N95 mask off and lay down in a clean bed and take a nap. And we've had I think thousands, I can't remember the number, but I think over 2,000, maybe more, maybe 12,000 visits to this room. We sent out messages to the community. I emailed every teacher I knew. I said, can you have your students just make pictures, whatever, send them to me. We had them emailed and we printed all of them. They're hanging throughout our whole hospital. We have a helpline. We have one for our chaplains and one from a psychologist 24/7. We post these tips on Teams, how to take care of yourself, and we provide daily meditation twice a day. You can join and meditate. So my most proud part of all this that I brought to the table is virtual pet therapy, which I don't know if this is like things that other people do, but one meeting I just said, you know what we need? We need pet therapy. And everybody laughed and they said, we can't have volunteers in the hospital. And I said, let's do it virtually. And this is Molly, and Molly sends us a picture probably every 3 days with some tips on how to wear your mask, how to wash your hands, how to socially distance, not to hoard, because she was hoarding her dog toys. But we have a recreational team that goes around with an iPad and they walk through the units. And Molly will bark for you, she'll jump, she'll catch a ball, and the reaction from the staff is amazing. We published an editorial on some of these things that's it's very brief, but it basically goes over some of the things that maybe you could implement in your hospital. We even did stretching, and at our huddles and in the morning, we would have a recreational or physical therapist come and do stretching with the staff. We did victory poses with the staff. It was all over the place, but I like to share that because I know we're all in the same boat right now. And just to close, these are some of the testimonials from our nurses. And I think this is really the proof of what Code Lavender can do for your staff. Code Lavender has brought change to our hospital environment. Togetherness and offering emotional support, open-mindedness. Now, I don't know what the culture's like in your units, but in our unit, it was not okay to cry when you had a bad case. It was not okay. And we're getting to a point now where if somebody's really feeling it, they'll actually say, I'm having a lavender moment. And that is the key, that they need support. And we've gone so far as to get little aromatherapy lavender stickers that our champions from the unit actually have them. And if somebody's having a lavender moment, you put it on their badge, and then they're able to have the aromatherapy of the lavender, which has been really well received. And I think that what we also determined is that our debriefs are very different now. They're not about blame. We are comfortable verbalizing our feelings, and we know that they're not abnormal, and it feels good to share and hear that we're not alone. As providers, we are taught to not to wear our feelings on our sleeve, to hold it in until you're removed from the situation. Code Lavender provides a forum to share and be heard so that these feelings don't eat you up from the inside out. Sharing is caring. And that was from one of the toughest L&D nurses that I've known over the years. I cannot express the importance I believe that this process, Code Lavender, contributes to us being the best, healthiest, empathetic, and caring providers. And then this is one of my very good friends. And I'm just going to tell you what happened because it's really powerful. She is a labor and delivery nurse for 12 years, and her niece came in with twins for delivery. And unexpectedly, baby B died at birth. Completely unexpectedly. The baby was coded for 20, 25 minutes in the delivery room and passed. And she had to go tell her sister that her grandson had died. So this was her response. The entire Code Lavender team provided ongoing support and helped me overcome this soul-crushing situation, allowing me to continue to provide the care that I know every patient in the acute setting needs. It was the first time in 12 years that I felt the hospital was providing support for me as a healthcare provider, allowing me to be a better nurse, mother, person. I want to thank the team from the bottom of my heart. So the second victim response, staff burnout, it's real. It's real, and right now in the pandemic, it's destroying our hospital. You have an opportunity to help create a culture of compassion amongst your colleagues, and you can implement Code Lavender or something like Code Lavender to help your staff get through it. And finally, I always have to remind this to myself, and that's we have to be kind to ourselves too, and realize that we're not perfect. So that's where it brings us here today. And I'm excited that there's people here from all over the world. I did not realize that was going to be the case, but I think that when we look back, we'll realize that this brought us all together. And I remind myself every day that we have the most amazing job, because as hard as it is to get up every day and know that you're facing this monster of a virus, we are still bringing life into the world. And we can do it in a beautiful way, even if it means that we're wearing our PPE. And those moms and dads, they will never forget those moments. And so I think we all have to remind ourselves of that as we face this burden. So thank you, everybody. Those are my two kids, Jackson and Emma. Jackson is virtually learning upstairs right now, or sleeping in his bed, one or the other. And Emma's actually at school. And I want to thank Sonova and my friend Lori Gunther, who hooked me up with Kathy and allowed me to share this very cool thing that we're doing here at Stonybrook. Oh, and these are my support animals that you heard barking before. That would have been the golden doodle barking at the UPS truck. And that's my greyhound. So thank everybody from the bottom of my heart for allowing me to speak. And just thank you for all you do every day, because you're doing pretty awesome things.
You are awesome. That was amazing. I don't know if there's a dry eye. I know, like, I cried the last time that I heard this. I cried again. I was trying so hard to hold it together, but like, it's just so touching what you're doing. But I think what brings like the emotion is just that I feel like it's that giving permission, right? It's like, we've all been feeling this forever. And it's just amazing. It's just amazing. So do any of you want to be brave and bring yourself on video and just give Megan just a round of applause? I always like to encourage you to come on video so that, you know, we can see each other's faces, and just give her a little claps and love and send hearts and everything. Yes, people are in love with this. And I think just being part of our community, it's good to just see your faces. We have not been together for many months now. So what are your questions for Megan? This is your chance to ask, like, how did you do this? Oh, I know. Thanks, Amanda. This is so great. People are wanting to know where they can find your references. Can you make a PDF of slides that have those references for them?
Absolutely.
Yeah. So what are your questions? Bring yourself on video, unmute, whatever you want. This is your chance to go for it, Kim.
My biggest question is, I work at a fairly small children's hospital in Omaha. And one of my coworkers has been trying to bring on somebody, mental health, psychologists, anybody to try to help our staff, because we've been going through a lot of stuff that's too long to tell. But do you think, and the hospital is just not budging at this point about bringing on any type of staff like that, do you think it's possible to start a program like this without that kind of backup?
Good question.
Yes, that's a great question. So I think it would be very difficult. Do you have chaplains? You do?
Yes.
Okay. Again, I can't emphasize this enough. Every hospital has a different culture. And our culture at Stonybrook is not that spiritual. And so when I started this, I really depended on the chaplains, because they're there 24/7. And what I learned very quickly was that staff were not responsive to chaplains. And these are of all faiths. It's not just, but there was something in our culture that wasn't clicking. And I had the very fortunate situation where Stonybrook hired a psychologist just for staff support. And I know, I have to be honest with you, I think it'd be really challenging, but that's why I mentioned the Cleveland Clinic and Johns Hopkins, because Johns Hopkins is really peer-based, and they have a lot of literature. They've published a lot of articles that I can send you the references, but they do not depend on a psychologist. They have a patient safety officer, and they do have a chaplain, and they basically train the staff how to be an active listener, how to ask questions without judgment. Again, we don't provide therapy, but if I show you how other places did it, I think that you'd find a way to do it. It's just
Kathy,
my experience was I needed the psychologist.
I honestly think we do too, but my friend honestly has been asking for over 25 years and has got no response from our upper echelon. So this is something that I would love to start without one.
Yeah, and that's also why I brought up the idea of selling it to your hospital and like what the benefits are, because there's literature that you can actually, it's cost effective to hire somebody like that. The reference is it costs 3 times more to replace a physician than to pay their salary. And so if you look in the literature, you can find ways to sell it. And we've managed to do that to a point now that I started with 1 psychologist. I have 5 now.
Wow.
Yeah, and it's really been like a really strong push, and we've expanded Code Lavender because of COVID. We were planning to launch it this fall. So in March, we went from just maternity and NICU to the entire hospital. And we were able to utilize our Microsoft Teams with 1 psychologist to provide themselves for everybody, because everybody could virtually join. And so that's how we overcame that limitation. But I can send you the information from the other hospitals and show. Do you have an employee assistance person, like an
Yeah.
EAP?
Yeah.
Because the
Yeah.
EAP person that's on my team is awesome, and she's a huge resource for us. So I pulled her in very quickly.
Okay. Yeah.
I was also wondering, Kim, maybe like you're connected with a university too. Maybe are there psychology students who need intern hours or?
We use those. I'm
Oh,
glad you brought that up.
free
We use
people.
interns too. Yes.
That's a great thought, Kathy.
I can't believe I forgot to tell you that. So yeah, we do these daily meditations twice a day, and we actually have our psychology interns doing it as part, and they're going to probably publish and they're going to get something from doing it.
Great. Okay.
Yeah. I was even
I would
thinking
take any information too. So
Yeah, I'll get you what you need.
Yeah, send to me and I'll just post it up with the recording of this and then people can just grab all of that. So there's a couple of questions, just they're looking for practical. So when that Code Lavender comes in, then what are the steps? So that phase 1 happens, the chaplain calls. I loved how you described it before, was like, it's like you're like the difference between having like tea with your grandma and going to therapy, right? So maybe talk people through the steps of.
This is a really good question, because this is a challenge because not everybody agreed with how to do this. And so the purpose of doing a pilot is to iron these wrinkles out. And so our pilot took 8 months and we had a lot of wrinkles. And so one of the questions is communication. So anytime a code is called, the chaplain responds. So now think about now COVID, there's a code, not to be dismal, but we have a code blue called like every 10 minutes, right? The chaplain's running around the hospital. How now are they going to respond to a Code Lavender? So what we've done, the operator actually pages a few people. So the chaplain will get the page and return the call to figure out what's going on. They may not be available to actually go there. And so now what we do is we have champions on each unit that will be contacted, and whoever happens to be at the hospital will actually just respond to figure out what do you need. So for my unit, I'm the champion. So if I go, the chaplain will call me and I'll go into the unit, or I'll call somebody on the unit, and then you figure out what happened, who was involved, and what do you need. And then the next person that I call is the nurse manager, because that's the person who's going to back it up and make it happen. I call the residency director because our residents are often involved, and so we need backup there. And then I call whoever the attending physicians are on the unit. And as a group, we figure out, what do we need? Does anybody identify as being in crisis? And if that is the case, I will communicate back to the chaplain that they need to go, that we need to figure out a way to get there. And so then that happens. And then I work with that group of people to figure out, lots of emails, what time works for everybody. Do you want to do one in the morning for the day team? Do you want to do one at night for the night team? And then we make it work. But it's a lot of time and it's a lot of energy. It's not really, the whole concept of the Code Lavender, and I've said this 1,000 times, it's simple. It's so simple to just be there for your colleagues. You don't have to bring anything, But let me tell you, the person who walks in with donuts is everybody's best friend. So if you can bring a box of donuts, that's great.
Yeah.
But it's simple. You just have to be present, and you have to have a really good communication system. So we use our Outlook email because it's safe to do it that way. But we also send a lot of text messages and a lot of phone calls.
That's so great. Someone asked, just when the call is made and you had made the statement, what do you need? So do you just rely on that self-report of what do you need?
So to be more specific, there's an individual call and then there's a group call. So for last week on Thursday, I had an individual call and it was just her. She was a nurse in the NICU. She had a verbally abusive father of the baby and she had to get out. She was scared. She was overwhelmed. She just needed to get out of the unit. And so when the call came in, she said, I need to just get off the unit. And so they contacted me and I took her off the unit. I got her Starbucks. We sat, she cried, and then she went back to work. When it's a bigger situation, and this is something you will find, a lot of times there's a problem between leadership and staff. That the staff does not feel supported by their leadership. And so this is a safe way for them to get help without their leadership really knowing about it. And they have a safety net. So they'll say to us, we need to have a Code Lavender, but we don't want our leadership there. Sometimes they'll say, we want a Code Lavender and we want our leadership there because we want them to hear what we're saying. So we work together to figure it out. And then sometimes they'll say, today a resident called me and I said, the residents are getting redeployed. They had already been deployed to the COVID units. And then the summer they were back on labor and delivery and they're being redeployed next week and they are in complete crisis. And so I said, what do you need? And she said, we need small groups of 4 or 5 people whom we trust to just sit with a psychologist and just help us to talk through it. And I said, okay, so that's what we're doing. So that's what I mean by what do you need? It can be just, sometimes people need a chaplain. They need to pray. They need a cup of coffee. They need to walk. That's a big one. I need to go for a walk. And you just walk out and walk through the hospital.
Wow.
I don't know if that answers the question.
Yeah, no, I think it does. I think the question was just trying to not put your own ideas about what they need in that moment, but to just ask and give what they've asked and not to read too much more into it.
The unit, it depends on the unit. If our psych unit, they need a Code Lavender every 15 minutes because their patients are violent. They're violent. They're being pinned to the ground. They're threatening to slice people's throats. These poor nurses are, I don't know how they do it. But they can't leave the floor. They're understaffed. So we say to them, what can we do? What can we do? And they tell us. We set up tea and coffee in their room and snacks, and they take turns and they each spend 10 minutes in the room and then somebody covers for them. So each unit has its own culture too. It's really, we leave it up to the unit to figure out what will work for your unit.
Wow. You guys have learned so much in this kind of crazy COVID time. Let's just roll out and just see what happens versus being probably as planned as you'd hoped. But let's see, someone's asking, when someone needs a walk, is that when the Lavender team steps in and talks to charge to cover? I'm thinking there might be pushback sometimes on that.
There is pushback and it depends on what's going on in the unit.
Yeah.
I will tell you, I've had someone call a Code Lavender and they said to me, so what do I get out of this? Do I get to go home? Now, I'm going to talk logistics. Where does that time come from? Is it their sick time? So these are the things you have to work out. I've met with labor relations. I've met with our union. I've met with every single person in our hospital to figure out how to protect our staff.
Yeah.
And so when you go for that walk, this is where the culture of compassion comes in, because when we started Code Lavender, it was a struggle. I'd have to find somebody. Can you please cover for this nurse? She just needs to go for a walk. And now it's implied. If somebody immediately, she called a Code Lavender. Okay, I'll step in and watch her patient. So it, like, the culture changed, but yes, there is pushback. There's pushback from one of our leaders in nurse leadership, who is not happy that she did not get credit for Code Lavender. And that's made a really difficult struggle because you need backup. You need people to support the staff.
Yeah. Yeah, that's great. Is there ever a time that you just can't meet the needs based on just business staffing availability? And how do you manage that?
I think because we have a tiered system of phases,
Yeah.
we have been, and that's why that came actually from Johns Hopkins, that information, that whole idea of having phases of response. Because we have that in place, I think ultimately we do meet the needs. But when there is a crisis at that moment, it's very difficult because of staffing issues.
Yeah.
But I think in general, if you look over the course of the week, we seek every person that was involved in the case, we seek them out. We find we'll say who's close to Sally that can contact her and ask her if she's okay. And so we utilize the other peers, the peer support system, to reach out and say, you had this really terrible case today. What can we do for you? And maybe she needs to talk to somebody. We have 5 psychologists that then will just speak to her, not patient doctor, just one-on-one. And if they determine they need therapy, they hook them immediately up with a therapist. Our staff does not have to look for a therapist. We bring the therapist to them and we set them up. So I think our worst Code Lavender that we had was a maternal death. A lot of people were involved, not able to really respond immediately. But what we ended up doing was ultimately 5 or 6 days later, we got every person back together. We had 60 people in the Code Lavender. So it's tricky, but you can make it work. And I think you have to really rely on the peers.
And I think I do really like that phased approach where you can get that just, I hear you, I see you, I'm here, I'm supporting you, and then trying to triage from there and get these other people involved. I was trying to read and think and talk all at the same time. Sometimes my multitasking brain doesn't keep up. I think we got it all. Jan had mentioned, I don't know, Jan, if you want to unmute, but she said she was commenting for you, Kim Marsh. We started our journey with a survey on moral distress, or similar to what you did, Megan, just to document the need. And that's
one of the ways that you sell it. You bring it, and Leapfrog and all these other surveys that are hospitals and they're trying to get their magnet status or whatever it is they're trying to do. And I can tell you, they checked Code Lavender off before it was even implemented. And I was like, again, trying to get credit.
Yeah.
Not giving me any, I had no budget. Everything is out of my pocket.
Wow.
So it's very difficult, but selling it, doing those surveys, we have a director of employee engagement. I walked into her room and I said, here, I'm giving you this. We need to make our staff happy and we need to sell it to the leadership. So the survey is a really helpful tool.
Yeah, that's great. Thanks for mentioning that again, Jan. Someone's asking, and I was thinking too, what about the social workers on the unit? Many of them have great mental health training on doing assessments. Have you found the social workers to be a really important part?
We have 2 social workers that have worked with me in the pilot. The director of social work is also the director of our mental health disaster team. So she's been on Team Lavender since day one. She was one of the first people I went to. So social work has been intimately involved.
Yeah.
And our 2 social workers are wonderful. They come to as many codes as they can, but we're a little understaffed with social work.
Yeah.
So they're a little strapped for time, but they're an excellent resource to use.
Let's see. People are saying, I love how your staff has come together to develop the culture of compassion. I think that's self-compassion, but also our colleague compassion. Now that there is more buy-in, is there financial support from your leadership? And I think you said yes, right?
Yes, we were approved from our CEO to have a budget. I have yet to see any of that money because COVID just distracted everyone from filling out the appropriate paperwork. But what we've actually now done is I actually found a private person who donated a significant amount of money to our Stonybrook Foundation in the name of Code Lavender. So we will be able to access those resources. But you have to look into your hospital because that's tricky. Sometimes they don't allow you to use those funds for things like food. So there's all sorts of things, but with more buy-in, yes, we've gotten the approval for financial support.
Yeah. I think her follow-up question, so when you buy a nurse a cup of coffee, it's pretty much Megan's card.
Yes.
Okay.
But we have people who donate things. So if we have that delayed response, I've had somebody whose husband works in a restaurant and they brought in trays of food. This was before COVID.
Yeah.
So again, you set the example.
Yeah.
I show up with a tray of Starbucks drinks and everybody's like, where did that come from? And I'm like, don't worry about it. And then you plant the seed. And the next time somebody comes in with a tray of donuts.
Yeah, absolutely. All right, guys, what's your final questions for Dr. Megan? You've got her here for a few more minutes. People are just saying they commend your advocacy. They just love that you've changed culture. There's just so many just thank you and thank yous here. And I just want to say thank you again. Like I said, we met maybe 2 weeks ago, texted over the weekend, and now she's here. And I just thought it was just a great way to end the year and to maybe just paint that vision of what's possible, because I feel like COVID or no COVID, the work we do is challenging and the work we do is sometimes painful, and we are that second victim. And I know we've all talked about that, but I think that this is such a beautiful and practical and detailed way of just painting that vision of possibility. And yeah, it will look different everywhere, but I think once you see it's possible, then you just find your way and just know that it is so important. And so just
don't give up.
Don't give up. I love that. Yeah.
Don't give up.
It's worth it. It's worth it. So I can't believe we made it to the top of the hour. That went so fast, but thank you, Megan, for being with us. I just can't say thank you enough.
Thank you, everybody. It really was a pleasure.
And if you want to come on camera and wave goodbye, this is your chance. But otherwise, I'll close the meeting in just a minute. All right. Bye, everybody. Thanks again, Megan.
No problem. Have a good one, guys.
Thanks,
Take care. Be well.
Bye.
Okay, everybody, was that not an amazing presentation by Dr. Lochner? And thanks so much to everybody who was on that presentation live back in 2020. Check the show notes below for a link to download the resources as well as the references. I hope you've enjoyed this first of our series on emotional and social caring in the NICU, and I will see you next time.